Well, welcome. Just when I thought I understood everything that was offered at the Milford Regional Medical Center, I find new gems to explore. I mean, it's amazing what Ed Kelly, Phil Sermicoli, what they've brought to our town and our area as far as services. Tonight we're going to talk about a very specialized service with very specialized surgeons. And we really appreciate them bringing their unique talents to the Milford area. But let's start with an introduction.
Sure. My name is Hassan Zaidi. I'm one of the neurosurgeons at Milford Regional Medical Center. I practice primarily spine surgery. My fellowship training is in spine, adult spine deformity. It's primarily patients who develop scoliosis later on in life as they get older as a result of run-of-the-mill degeneration of the spine.
My name is Omar Arnaut. I'm also a neurosurgeon both at the Brigham and at Milford. And my practice has two focuses, spine surgery, especially minimally invasive spine surgery, as well as brain tumor surgery.
Minimally invasive spine surgery.
Yep.
Why does that sound like oxymoron jumbo shrimp?
Not at all. So it's actually been around for a few years, but it's like most things, we keep making it, I think, better and better. The basic principle is you must be able to achieve your goal at the end of the operation. You can't compromise your goal, but you have to be able to do it through a smaller and smaller incision and less disruption.
So now when people think of neurosurgery, most of the times they don't think of neurosurgery. They have no idea what y'all do. Why don't we start with, now it's the Brigham. What is the official title of the new group?
It's Brigham Women's Neurosurgery at Milford.
At Milford. So you're bringing a pretty hefty name with you, with the Brigham. I mean, that, first of all, seems impressive to me that I can be out in Milford and be treated by surgeons from the Brigham.
Yeah. So at Brigham and Women's, neurosurgery really developed as a subspecialty. The first chairman of Brigham and Women's Neurosurgery was Harvey Cushing, who, as you probably know, really started the American experience of adult neurosurgery. And he trained a lot of the people who influenced neurosurgery in not only the United States, but also worldwide. So it's really an honor for us to be able to bring that experience that we have learned through people who've trickled down from Harvey Cushing's era and bring it to the community at Milford.
Now, when somebody comes to you, or, Daddy, what do you do? How do you explain neurosurgery?
Well, first of all, it is unequivocally the greatest job in the world. It's a massive privilege to be able to do the work that we do. So it's surgery. It's fantastic because you get to see the effects of what you do on a day-to-day basis. Our typical day is either in clinic or in surgery. In clinic, you see patients, some of whom have had surgery, some of whom may be good candidates for surgery, many of whom don't actually need surgery, and that's a big part of it, is figuring out who would benefit the most from having an operation. On days that we are in surgery, we're either doing, sometimes if you do spine surgery, you can do a couple in a given day, and you spend your whole day focusing on that. You do nothing else that day. If we're doing a brain tumor operation, usually it's one per day, and then that takes up your whole day, and you're really focused and dedicated to that enterprise.
So you are the proverbial brain surgeons that everybody always
That's
talks
the brain
of.
surgeon, yeah, that's right.
You always say, well, this isn't brain surgery.
Yeah.
Well, now we do have brain surgeons to talk to. Now, when would I even come to your practice?
So, neurosurgery covers a wide variety of issues. So you have, as Omar mentioned, patients with brain tumors. That would be someone who presents with a headache or something more concerning like a seizure or something that's found after a routine head scan after a car accident. So that's one pathology that would bring you in to see a neurosurgeon. The other things that we treat and that people don't know about too much is pain. Spine surgery in general historically has been something that an orthopedic surgeon or a bone surgeon is often taken care of. In the last 20 or 30 years, it's really shifted. And now most of the big spine societies are actually dominated by neurosurgeons. So neurosurgeons are doing more and more spine procedures, and that's actually compromises more than 50% of our practice in general amongst the whole subspecialty. And we also treat things like Parkinson's disease and chronic pain, and also chronic seizures. So there's a wide variety of things that neurosurgeons can treat. Often the patients that we see are patients that have been evaluated by a primary care physician or through the emergency department. So often it's someone that you don't see up front, someone that you see after you've been gone through the system in terms of seeing the frontline physicians.
Now, most of your patients, I think of chronic diseases, scoliosis, something that grows with me. Is it more that, or is it more like an acute accident or a point source?
It really spans the whole spectrum, so it's some of it is very acute. Scoliosis is a great example of that because that develops over decades sometimes. So does degenerative disease of the back or the neck. That happens. It's a wear and tear phenomenon. It happens over years. But if you get hit by a car and you've got blood in your head, that's a more acute thing. If you're walking around minding your business and you have a seizure, and the next thing you know you've got a brain tumor, that's a more acute kind of issue. So it really spans the spectrum from things that are very urgent and acute to things that have been around for years.
But now, when I think of acute, car accidents come to mind,
Yeah.
skiing accidents. How does it manifest itself? Okay, I was in a car accident.
Well, it depends if you're talking about the brain or the spine. If you're talking about the brain, it is almost always in association with a head injury. There's always usually a clear head injury, and often a loss of consciousness. If there's loss of consciousness in the setting of a head injury, that's a big red flag.
Now, a head injury, I got banged.
Yeah.
Okay, if you do a scan, maybe you can see something, but
Depends.
how would you know?
Depends on how hard you get banged. Usually you can actually tell by examining somebody. If you're in the ED and a surgeon is called to come by and see you, usually by doing a good physical exam the old-fashioned way, you can almost always tell if there's something wrong.
So Jeff Hopkins calls you and said, I need a consult.
Yep.
Come on down.
Yep.
What are you looking for? Is it a bump on my head or?
Well, loss of consciousness is one of them. You get a history and you find out that is, and then you look for physical signs. If you've got weakness on one side of the body or another, even if it's subtle, that could be a sign that there's something going on, and it's a good idea to get a CAT scan and investigate that further.
Neurosurgery has become more and more dependent on technology. I think that's going to be the overall arching theme. We've been trained in the era of purely being able to diagnose things with an exam as much as possible, but we corroborate our evidence, physical exam findings, with technology. It's driven primarily by CT scans or MRI. And that also flows into the operating room. You're only as good as your tools are. So in the operating room, we depend a lot on our tools just as much as our hands to be able to perform the procedures that we need to do.
So now let's take a little sidestep. You look awful young to be neurosurgeons. I always wonder why physicians go into subspecialties, because it feels like they're going to be a retirement age before they're done with their studies. And why neurosurgery?
Well, for me, I entered medical school, and I didn't know what I wanted to be for a very long time. My parents owned donut shops, as we talked about before, so I didn't really have any legacy to follow. And I went into medical school thinking, I want to go into work every day happy. I want to be challenged, and I think a lot of medicine provides that. What specifically drew me to neurosurgery was the fact that neurosurgery is constantly evolving, constantly changing. The big questions have not yet been answered. And every day that we think that we know the answer, there's a new study or a new technology that develops that helps us understand the brain, the spine better, and treat diseases of the brain and spine much more efficiently, effectively, safely. So that's what really drew me. I was part of a community that was constantly trying to evolve, change itself, and it wasn't stagnant. And I think it also comes down to personality. You meet people that inspire you and that make you want to do what they're doing. And I just happened to meet the right people. When I was in medical school, it was really the chairman of neurosurgery at Johns Hopkins who developed a wafer that you could basically place in the brain after taking out a brain tumor, and that would dissolve over time and deliver chemotherapeutic agents. And that changed the course of brain tumor surgery. He was just one man, but developing that technology changed, saved thousands and thousands of lives. So that was that was primarily why I wanted to go in. Yeah.
Well, I got a very different answer for you. So if you had asked me when I was 16 years old, I would have told you I was going to be a brain surgeon. It was pretty clear cut for me. So my grandmother had brain tumors when I was a kid, and I got to meet her surgeon. And he actually, in those days, was a VHS. He gave me a VHS of her surgery. And as a teenager, I found it fascinating. And I remember watching that thing over and over again. And I told my parents I was going to take those out one day. It'll be me taking those out. And so I went to college just so I can go to medical school, just so I can do neurosurgery training. So,
now, how do you answer the question? Being a brain surgeon isn't good enough? You had to be a neurosurgeon with the spine too?
Yeah, well, you know, it's the field is actually pretty diverse. It's brain surgery, spine surgery, it's also peripheral nerve surgery, you know, things like carpal tunnel. Anything where nerves or the central nervous system is involved, we help take care of.
Now, it's got to be critical to a patient with carpal tunnel. But one hand I'm playing with your wrist, the other hand I'm playing with your brain. Are you drawn to one or the other?
I think in general, at least has been my experience when you talk to surgeons, there usually is some tendency towards one field or another, which is a good thing because you get to kind of develop those particular skill sets a little bit. But to be honest with you, there's quite a bit of overlap. The attention to detail, the techniques, the microsurgery, the planning, all that stuff is common to our field in general. And if you know the principles of taking care of the spinal cord and the brain, you can apply those principles widely. But in general, you're right, people do kind of have little areas of interest.
I remember in training, my mentor said, you know, neurosurgery is like riding a bicycle. You're going to be able to ride a bicycle better than the other guy if you just do those motions over and over again. Part of it is muscle memory as much as it is, you know, developing the experience to expect the unexpected.
So now, besides 100 years of training, I mean, walk us through. You go to college.
Yep.
And then you go down to Wolf Street to that little college in Baltimore. But seriously, you got 4 years of college. Then you go to medical school for 3?
4.
4.
Yep.
So you're already in 8.
You're already in 8, and then you got to take all these exams, and prove yourself over and over along the way. So 4 years of college, 4 years of medical school. Then it's 7 years of neurosurgery training. And then on top of that, most of us, the two of us included, but most surgeons take another year or 2 on top of that to do some subspecialized training. So it winds up being about
17 years.
Yeah.
You are ready for retirement when you
That's
come
right.
out.
Yeah.
Wow. So where did you go to school?
I went to undergrad at WashU in St. Louis, and then I went to medical school at Northwestern in Chicago. I stayed there for my residency for those 7 years. And then I came to Harvard. I did a year of fellowship training in complex brain tumors. And then I went to Sydney, Australia, and I did some more training in minimally invasive brain surgery.
Why, did you get somebody mad at you?
Yeah.
They sent you to Sydney?
As far away as possible. Yeah.
That's great. I went to UCLA for college, and then I went to Johns Hopkins for medical school, and then went back to the West Coast for training at this place called the Barrow Neurological Institute. It's actually one of the biggest neurosurgical institutes in the world, and then did a fellowship there in complex spine deformity, and then actually did my fellowship also here at Harvard in endoscopic minimally invasive surgery.
So you left LA, you went to Baltimore and got scared of the weather and went back to the West Coast.
Yes, bi-coastal, as they say, yeah.
I guess. I was going to say, it'd be hard to leave Southern Cal with that weather and come up here.
Yeah. See, I'm used to it. Chicago,
Well,
Midwest.
Chicago is the same
it's
as
all
us.
the same. Yeah.
So now, when you talk about the instances that would drive you to brain surgery, and then to neurosurgery, and then to peripheral, brain surgery, tumors, how do you go in and cut out part of somebody's brain?
You mean physically? How do you go in and do it?
Physically, I mean, how would you decide? I mean, tumor bad, got to get it out. So now you got to decide, do you do the chemo where you're trying to kill the patient a little slower than the tumor?
Yeah. So, the short answer is it's very complicated. But so what goes into it is it's very personalized. You really got to treat the patient sitting in front of you, not the scan. You got to try to identify what kind of tumor it is, what the prognosis is, what the risk-benefit ratio of doing an operation is, and that's all going to make sense. And it's got to fit in the bigger picture, the patient's age, the social circumstance, what they value, what they consider good quality of life. So it involves a whole lot of planning on our end, but also a lot of conversation with the patient to see if it all makes sense.
Is there a prevalent location, like most brain tumors are here or there?
No, it kind of depends on what kind. There's many different kinds of brain tumors. And fortunately,
Well, you say that, sorry to interrupt,
Yeah.
but most people, brain cancer, that's it. They've stopped listening.
yeah, well, the reason that happens is the most common kind we see, unfortunately, is brain cancer by numbers. That's the most
Really?
most common thing that we see. But it varies in location. It can be in different spots in the brain.
So now, is it, I hate to say self-induced, but is it due to environmental factors that I have control over? Or, like lung cancer. There's a good set of data that says if you smoke a few packs a day, your odds on lung cancer are much higher than if you don't.
Yeah. Not so with brain cancer, unfortunately. There's some, if you get radiation to your head for some reason or another, if you've had cancer on your skin, for example, and then give you head radiation, that can increase your risk, years and years down the line of getting brain cancer. But outside of that one particular scenario, there's nothing that any of us can do to increase or decrease our chance of getting
Now
it.
that's confusing. So if I had skin cancer,
Yeah.
and I would think they isolate the
No,
beam.
if you had like a melanoma on your face or something that needed radiation to the face, or head and neck.
So it's not going to be like general radiation anywhere. It's somewhere really close to the brain.
But that's a very uncommon scenario. The vast majority of people have no good reason to get it.
Yeah, in the 50s, kids would get treated for fleas with radiation to the head. And so we found that radiation exposure is not benign. And that, those patients would come 50, 60 years later with a brain tumor. It's a very, very small subset of the overall population, obviously. But for the most part, I tell patients who come in with a brain tumor, it is just bad luck, unfortunately. It's just a random, spontaneous mutation.
So it's not that it metastasized from somewhere else and moved up?
Well, that's a whole different category. So there's primary brain tumors, the ones that arise from the substance of the brain itself. That's the one I was referring to. But if you look by numbers, there's also cancers that start elsewhere in the body, breast, for example, or prostate, that then wind up metastasizing to your brain. So the two different ones, both unfortunately, are things we see
Do
often.
they cross the blood-brain barrier? How do they get there?
They do one way. So if you have cancer elsewhere in the body, it can cross and go into your brain. But the brain cancers themselves, the ones that originate in the brain, can't cross the other way. So the ones that start in the brain stay in the brain.
Oh, good. So the way I don't want, the one in my brain I want to get out,
Yeah.
go take a vacation,
Yeah.
go down and bother my foot or my liver, they can't cross the blood-brain barrier.
No.
Strange. Why?
The brain is created in a way to protect itself.
Mm.
We've evolved. It's the most sensitive organ, so it's created this barrier to prevent infections from falling through or changes in the molecules in the bloodstream from penetrating into the brain. So it's created this natural barrier, and in some ways it can help, and in other ways it certainly doesn't. So when we try and administer medication, unfortunately, the medication doesn't penetrate through the blood-brain barrier like it would for other organ systems. So a lot of the research that's really been driven now recently in brain surgery is really trying to penetrate through that blood-brain barrier. And a lot of companies, a lot of careers have been built on simply answering that question that you're asking.
So we've evolved to a point that the assumption is the brain is pure.
Mm-hmm.
But if I get a random mutation, dang it. I didn't expect, I locked myself in this room. A wolf just jumped in the room, we don't know from where, so now I got a problem.
Yep.
There's 100 billion brain cells, and you just need one to go wrong for there to be a problem. So,
And they don't change, do they? It's not like liver where it can regenerate.
Yeah, it's very tough. The brain, you can regenerate liver, you can regenerate muscle cells. The brain is, what you're born with is essentially what you have. So if you lose part of it from a stroke, for example, or from any other insult to the brain, it's hard to recover that portion of the brain, but the brain does have some plasticity. especially the younger we are, the more of it we have. And what that means is that other parts of the brain can take over some of that function.
I mean, there are children who are as old as 9 years old. You can take out half their brain, for a variety of pathologies. And if you saw them today as adults, you probably would never know that they had
Really?
the brain. Yeah, the brain is extremely adaptive, so it's able to take on function that it's lost only up to a certain age. Obviously, if you do that to one of us now, we'd be devastated. But children especially...
Yes, my wife should probably say that explains a lot of things. But now, we read years ago about applying stem cells to areas of the brain to help. Instead of deep brain stimulation and techniques like that for Parkinson's. Stem cell done anything lately, or?
It's an area of very active research. It hasn't quite reached the stage where it's able to help us regain function or recover parts of the brain. It's also a very active area of research in spinal cord injury, where people are in car accidents or other kinds of accidents and lose function in their arms and legs. And people are using stem cells to try to help them recover some function. So it's a very active area of research. It's not quite there yet.
I remember there were companies like Alceris on spinal cord, that if you could apply their agent within 4 hours of a massive spinal cord injury, you could actually go from a condition 4 down, whatever it was. But again, you always wondered, how are you going to staff somebody at all the institutes or all the medical centers? Because it's not going to happen very often.
Well, so I think that's part of it, but also if you look at the numbers in the papers versus the clinical, how much better people actually get, that's where the discrepancy comes from. We do have the ability, for the most part, if you have a stroke, we have the ability now as a field to get you into the hospital, get you into the appropriate part of the hospital within, say, 90 minutes from the second you hit the door until you get an intervention. So we can actually get you an intervention quickly. So that's usually not the rate limiting step. I think the technology, the actual intervention that we're doing for that scenario just isn't where it needs to be just yet.
And I remember when Jeff Hopkins came in, and he started talking about stroke prevention. It was amazing because, being an old, you two are too young, but when you get old, you want to be manly man. And I can live through anything. And he was saying, I think it was like 2 million brain cells a minute or something, that if you've had a real stroke. And he looked and said, how many you want to lose before you admit it? Is it gotten better? People's awareness better? Because Jeff told us it was simple. I mean, if you think you've had a stroke, the idea of have a stroke buddy. Nobody wants to admit, especially at my age, that I could be less than manly and see through everything. So he said, call somebody and say, hey, Omar, how do you feel? Hey, you sound good. Great. Then I know I don't have, but hey, it's slurred, or I can't understand you, or I'm getting numbness. It seemed like 2 or 3 really basic steps you could take. But are people aware now, or?
I think it takes time to diffuse into the community, but if we can use the show as sort of a venue to emphasize to people that time is brain. If you're ever concerned at all, come to the nearest emergency department. And those symptoms, like you just mentioned, Al, confusion, slurred of speech, weakness on one side of the body versus the other, all those things are obviously extremely concerning symptoms. And the quicker you can get to a hospital, and the quicker you can get to intervention, the more brain you can potentially save if you truly have a stroke. And I think people are becoming more and more aware of that. There are actually institutions that have CT scanners or scanners in an ambulance, so you can get intervention immediately. There's ways to intervene in an ambulance for stroke. Stroke is really as a result of blockage of an artery, and you can give medication through a simple intravenous line that can eat up the clot, and that can dramatically save brain immediately. But there are other patients who simply are not candidates for those procedures, so they require treatment at a tertiary care center. So the quicker you can fly them into a hospital, the more brain you can potentially save.
I remember when it was described, ischemic, it's not a stroke.
Yeah.
Mm-hmm.
So if I'm giving blood thinner to somebody who's bleeding, probably not a good deal. So,
Right. So that's what the ER would do, for example. If you give them signs of a stroke, the first thing they would do is they would make sure it's not hemorrhagic. In other words, it's not a stroke because you've bled into the brain. Rather, it's a stroke because an artery was clogged. and they would hold off on administering those medications until they've done that, which is the impetus for putting CAT scanners in an ambulance, so you can figure out which category folks are in as soon as possible.
Does that sound amazing? You're going to scan my cat in an ambulance. You know, you think about when the CAT scanners first came out, their size and expense, the idea of having them perform a function in an ambulance amazes me.
Yeah. Well, we've got mobile CAT scanners now. You can bring a CAT scanner into an operating room. We use it quite a bit for spine surgery. Some of the more complex spine surgeries we do, it's somebody just wheels it in the middle of an operation, and you can
Seriously?
you can do a CAT scan on the table. Yeah.
That's amazing to me. So, if I even think I'm having a stroke, tell me again the signs that you would say go through.
Numbness or tingling on one side of the body versus another.
Is it left arm or is it both?
So, in the majority of people who are right-handed, 95+% of people who are right-handed, the left brain is dominant in terms of language function. So if you're having a left-sided brain stroke, the left side of the brain actually controls the right side of the body. You know, if you're a right-handed person and your family notices that you're not talking appropriately and the right side of your body is not functioning normally, it usually means that it's a left-sided event of some sort. It doesn't necessarily have to be a full-blown stroke. You can have quote-unquote mini strokes, something called a TIA or transient ischemic attack, where you can have stroke-like symptoms that come and then go away spontaneously, and can happen for a variety of different reasons, and it doesn't necessarily mean that you had a stroke. The other symptoms include, you know, complete paralysis on one side of the body, and rare cases you can potentially even have seizures. You know, if you have a stroke and you have a bleeding event into the stroke area, you can potentially have a seizure or just be completely unconscious at some point. So if you're ever alone and you're worried about symptoms of a stroke, it's important to have someone that you can contact immediately. If you're there with a family member, you should probably be taken to the nearest emergency department. It's important not to go to a center that primarily just deals with stroke if it's an hour and a half away. It's best that you go to your nearest emergency room.
Well, again, you
physician.
thought, 2 million cells a minute.
Mm-hmm.
And I bought when I was born, which is like 2 billion?
100.
100 billion?
Yeah.
So even 100 billion, if you're eating up 2 million a minute, you can eat that up pretty quick.
Yeah, it's not a whole lot of time.
You know, so this idea of a manly man, I can see through it, seems like the silliest thing that anybody could do.
Yeah, I agree with you. Plus, by being available at Milford Hospital, there's now certain categories of stroke that we are taking care of and observing the whole time and keeping them at Milford Hospital, which is great, I think, for that disease process, because it's always great if you live in the area to be able to be taken care of for that kind of thing close to home, where your family can
So
come
when you
see
talk
you
about
and
a
check on you.
hemorrhagic, a bleeder, what is that really? Is it a vein that popped in your head, or?
Well, it could be either. So you've got veins and arteries. The arteries can bleed, and those are pretty bad. Usually that's in the setting of an aneurysm, which is a weakening in the wall of the
So I
blood
get a
vessel.
little bubble in the vein,
You
and
get a
all of
little-
a sudden, for anything I did, or just bad luck?
For aneurysms, there's quite a few things you can do. You can have bad genes, but the big one really is smoking. Smoking considerably increases your risk of getting an aneurysm, and if you have one, it considerably increases your risk of rupturing that aneurysm. So smoking
Because it's a vasoconstrictor, or?
No, it just eats up. Smoking, you know, we always think about smoking as bad for your lungs, which it
Right.
is, of course, but it's actually bad for everything. It's bad for your skin. It weakens the ligaments, the things that hold us together, basically, and all the connective tissue. And that's how it causes aneurysms. It just weakens the wall of those blood vessels. It also weakens your spine. It helps everything break down faster.
Well, that explains that. So much for me being a smoker. I get my cigar every 4 months. Now you're making me feel guilty. So that would come, I mean, that's something I can control.
Yes, that's
I can give
that's
up
a
my
huge thing.
cigar 3 times a year when I celebrate things, but
Right.
it's really set up for people who are smoking heavily or cigarettes.
For people who have high blood pressure that's uncontrolled for a very long time, that's also directly related to your risk of developing some sort of stroke. And, you know, it's something that you should see a primary care physician on. High blood pressure. My mom has high blood pressure. Doesn't necessarily always want to take care of it. Doesn't want to see her primary care doctor, but it's important to check off all those things with your PCP and see your physician regularly.
And taking care of it. Okay, so losing weight so I'm not as rotund. Okay, taking was it lisinopril or whatever.
Mm-hmm.
Oh, that doesn't seem like an overly burdensome event. My darling bride's got me on a dog food diet. And, it's good food, but it comes in little containers about that big. And unfortunately, it's working. My, blood pressure's down because I've lost 10, 15 pounds. My sugar number's down. If it didn't work, in a way, I'd be sad, but in the other way, I'd get to eat everything that I want. But, when you think of door number one being that long bus ride, hopefully north, but not south, or doing some of the little things, like losing weight, behaving a little more, a little exercise, no matter how much I don't like door number two, I really don't want to deal with door number one. So, it gets to a point where, you just have to take care of yourself.
Yeah. And the things that are good for you in general are good for your brain. You're right, losing weight, making sure that your diabetes is under control, your blood pressure is good. All those things are good for you in general, but they're also good for your brain and your spine. Losing weight is one of the best ways you can help your spine health. So it's just...
Now talk to me about spine, because, I think of getting into a skiing accident or something where, is it that I rupture my spinal cord? Is it that I just bruise it? What are the big problems you face with spinal injuries?
So spinal injuries are often extremely dangerous. So if you have a spinal injury, that's typically people, when they say spinal injury, something of injuring the supporting structures around the spinal cord. The spinal cord is basically a wire that connects your brain to the rest of the body, and it's supported by bones and ligament that protect it. And when you have an injury, you typically break the bone that's surrounding and protecting the spinal cord, and it can push on the spinal cord, and you can have symptoms like weakness on one foot, one leg, or bowel and bladder problems, But more often than not, when people come to the hospital for back problems, which, by the way, is one of the most common reasons to come to the hospital to begin with, people often develop symptoms as a result of degenerative changes. So it's something that happens as you're using your spine over time. Your spine is a mobile structure, just like any other, mechanic
So I
object.
get X million bends, and I've started to use too many of those bends already.
Mm-hmm.
It's like anything, the body wears.
Exactly. It's just like a car. If you're going to use your car often, instead of keeping it in the garage and polishing it all day and not doing anything to it, the car that's being used every day is going to have more and more normal wear and
you
tear.
got 100, 200,000 miles, you're going to have more maintenance issues.
Exactly. So when people come in for back problems, it's a result of this degenerative change, and that can result in pinched nerves. That typically causes pain going down the leg, or sometimes weakness in one.
So explain to me how something got in there and pinched my nerve.
So you have, you have bones that support your spine, allow you to be erect, and then you have something called a disc. A disc is sort of the shock absorber of the spine.
It's a little pillow in between the vertebrae.
Exactly, and that, as it bends and twists as you're doing your normal everyday things, the covering of that disc can have little fissures or can have a little crack. And within that crack, disc material can herniate out, and it can push on nerves or sometimes the spinal cord, or sometimes something called a cauda equina, which is the collection of nerves at the bottom of the spinal cord.
So I've got two vertebrae, and in between I got a nice little pad.
Mm-hmm.
Does the pad, when it degenerates, does it squish down?
Mm-hmm.
Or is it deforming, or both?
Both, typically, yeah. And just like Omar mentioned with smoking, that degeneration happens quicker in people who smoke or who don't take care of themselves, or are typically sedentary. So it can start to collapse, and as it collapses, just like toothpaste, it'll squeeze off onto the sides. Or sometimes you can have complete vacuum disc, where you essentially have bone-on-bone degeneration, and that can sometimes cause pain in the center of the back. And sometimes.
So when they talk about a pinched nerve, if that cushion is not of optimum size shape.
Mm-hmm.
The bones can come together in an unnatural way, and all of a sudden the nerves inside
Exactly.
are getting pushed upon? Is that what they mean by a pinched nerve?
More or less. So you have, the nerves, the bones exist primarily to protect the nerves and the spinal cord. So if the bones and the discs in between them are degenerating, either that disc material is floating backwards from the place it's meant to be towards where the nerves are housed, and that pushes on the nerves. It doesn't take a whole lot. The nerves are designed to work and have a lot of space around them, and they float freely in spinal fluid. And it doesn't take a whole lot of, they don't tolerate a whole lot of pressure. It doesn't take much to set them off.
But now if two of the vertebrae down low, up high, whatever, start pinching, does that cause pressure along the whole spinal cord, or?
Well, so what happens is we nowadays think about the whole spine as a unit.
There's a conduit almost.
Yeah, and we used to think about it as separate segments, your neck, your thoracic spine, and your lumbar spine. And we're moving more and more towards thinking about it globally. So if you have a problem at the very bottom of your spine, it may actually be related to how your whole body is aligned. And that goes back to the concept of scoliosis. It may be that your alignment, the way that you're standing, is abnormal because of some of the wear and tear degeneration. And that's causing you to have issues like back pain or more pinching of a nerve that you'd have.
So as I get older and I'm bending,
yeah.
right, because of degeneration, I come to you and, okay, I don't know why I'm doing this, but I'm not happy about this. What can you do?
Well, so that's called kyphosis. That process where you're bending forward is called kyphosis. And there's a saying in neurosurgery, which is that aging is a kyphosing process. That's what happens to all of us, to different degrees as we get older. If you have such significant kyphosis that when you stand upright, your head is not basically over your pelvis, that leads to the muscles in your back working overtime. They are working.
Now they're stretched.
They're stretched, and they're really working to try to pull you back into a neutral position. And that can cause a significant amount of back pain, a very significant, disabling amount of back pain that ruins people's quality of life. In those scenarios, there are some really good surgical options that we can do to basically help straighten you out.
What would you do?
So there's a variety of options. I mean, I think neurosurgery has changed so much in the last 10 years. I mean, when Omar and I were training, the surgeries that were recommended were often very big incisions, big exposures, a lot of bleeding, a lot of hospital stay. But because of the new tools that we have, we realized that we don't have to fix the whole spine. We just have to fix one segment, sort of kicking your spine back into normal alignment. And we can do that with much smaller incisions. Sometimes we make an incision just below the belly button and come from up front. Sometimes we can make small incisions off to the side. And we've realized that just by fixing one segment very, very well and placing something called a hyperlordotic cage, which is something that has really been in vogue in the last 5 to 10 years, you can really bring someone's alignment into much more of a natural state. So you don't necessarily need the big surgeries anymore. You simply can fix 1 or 2 segments, and that really brings someone's pain into much more of a controlled fashion because now their head is directly over their pelvis, so they don't necessarily
Now my muscles are operating within normal parameters.
Exactly.
So now when people talk about having vertebrae fused, that's always confusing to people. I mean, they're supposed to be there so they can bend. I mean, if you had a straight, you think of a conduit. If I had a straight pipe, I'd be nice and straight, but I don't think I'd have much quality of life or mobility.
Right.
So why would you fuse my vertebrae?
The most common reason that we fuse somebody's vertebrae is there's abnormal movement. You're right, the spine is designed to have some normal movement part of it, but there are some reasons why you'd have abnormal movement. Some of it is trauma. If you've had an accident and you've broken your spine, those bones are not moving normally and need to be fused so you can fix that broken bone. But some of it is also degeneration, as the bones, the wear and tear phenomenon. Again, that can lead down the line to some abnormal movement of the bones on top of each other. So the primary reason we would fuse somebody is if they have abnormal movement.
But now, when you say fuse, I thought I got 2 vertebrae. They were fusing them together this way. You're saying I could have had one vertebrae that cracked. and you're fusing it back together to be normal looking.
Well, yeah, not necessarily. So if you've had a car accident and you've broken a vertebrae and the fracture is so severe that you need an operation for it, we usually in that scenario would go in and clear out some of that fracture and then fuse the vertebra above and below that to each other, eliminate the movement at that whole level.
But now you're fusing 3 vertebrae.
Right. Well, it depends on the kind of fracture that you have. It's different because it's just the shape of those bones. It's different than the bones you have in your arm, for example, or your leg, which are long bones.
But what does that do to my move? I mean, better that I have limited movement than I cut the spinal cord and I have no movement.
Right.
But when you fuse 3 vertebrae, doesn't it sound like a lot?
It depends on which ones you fuse. A lot of your movement comes from certain ones. So, for example, we do neck fusions, again, for a variety of different reasons. And depending on which ones you fuse in the neck, you potentially would have no noticeable change in your range of motion.
And we have the ability now, again, with new technology, not just simply to fuse, but also to replace discs. So,
Replace a disc?
Mm-hmm.
Mm-hmm.
It's not taking out a cadaver disc and putting it in you. It's basically a ball that hovers over a sort of a cup, and it replaces the motion that disc was supposed to do with a mechanical object. And we found that when we can do that, we can actually preserve motion. Even if it's at one segment, it can preserve that motion of that one particular segment of the spine. But more importantly, when you fuse one level, there's always a risk the levels above and below can start to degenerate quicker.
They're going to be affected and have a faster degeneration.
Exactly. So when you can replace a disc, it's always much more ideal, if possible, depending on your particular pathology.
And you can do that with cadaveric discs?
We do it with mechanical
Oh,
objects, yeah. And that sort of replaces the motion into the ball and cup valve sort of motion of that mechanical
I
disc.
remember when I tore my ACL, they gave me the option of cutting part of my ligament and
Mm-hmm.
putting it in, or going to get a cadaveric ACL. And I said, well, if I do this, I want you to go kill a young guy, because I got enough old man's parts in me. I at least want one good, young man's part. But so really, you're not preserving discs from cadavers.
No. We basically replace that motion. So the motion of your spine is about the same. And we've realized more and more that if you can preserve that motion, that you prevent degeneration, accelerated degeneration above and below.
So now you mentioned you're involved with people with Parkinson's. That seems like an amazing field to me. I mean, we were fortunate. My darling bride worked on a fundraising group with a kid called Michael J. Fox.
Mm-hmm.
And once a year he did a big thing in New York to raise money for Parkinson's research. So you got to see firsthand, as we talked at dinner, even Muhammad Ali, which amazed me. Because at that point, you sat there and said, what an amazing life, but he could barely control himself.
Yeah.
What parts of Parkinson's treatment do you get involved in?
So it's a very disabling disease, as you know. So the surgical treatment, again, it's all about patient selection. There are some patients with certain criteria who really benefit quite a bit, and it's very dramatic surgery.
Is that like deep
brain stimulation is
stimulation?
that's kind of the standard, but nowadays we have minimally invasive ways of doing that too. So there's a technology called focused ultrasound that doesn't actually involve an incision at all. It's using very high frequency specialized ultrasound to target areas in the brain that we know are involved in the circuit that produces this phenomenon that we call Parkinson's disease. And it is a very satisfying disease to treat surgically, again in the right person, because as soon as you hit the right spot, so to speak, and turn on the stimulator or do the ultrasound, their tremor, which is very, very disabling, it's literally like flicking a switch, and it just goes away.
It's really remarkable. I mean, if you look back at the history of neurosurgery, most of the first 80 or 90 years of neurosurgery, this is a very nascent field starting from the early 1900s, was simply reducing the progression of the disease. But this is truly reversing the whole disease process. It's restoring functionality. And patients can go from being disabled to going back to work and functioning normally with a deep brain stimulation.
But I thought, is it a dopamine receptor that gets desensitized? Or I thought once you started, like on some of the drugs, that eventually the receptor sites got desensitized and there was no way back.
Yeah, so there is this pathway in the brain that eventually a breakdown in the pathway, one of which is the dopamine receptors. But it's the breakdown of that pathway that leads to this constellation of symptoms that we call Parkinson's. And the way that deep brain stimulation works is by augmenting different parts of that pathway to kind of compensate for that deficit.
It's kind of like a circuit enhancer in an electric circuit.
Yeah.
Kind of boost the signal and
Right.
compensate.
Exactly, yeah.
And that's just one circuit. I mean, we're scratching the surface now on what the brain can do. I mean, we don't know so much about the brain because we're just really starting to learn about all these different circuits. And so I think other pathologies that patients can have can be potentially treated down the road with functional neurosurgery.
So now, a couple times, Hassan, you've mentioned the tools are so critical. The technology, this is evolving so fast. Two questions. People look and say, well, I know you're from the Brigham. All praise to the Brigham, right? But if I go into the Brigham versus the Brigham at Milford, am I getting less quality care in Milford than I do at the Brigham?
No, absolutely not. I mean, Omar and myself, we both spent half of our time at Brigham and Women's Hospital and half of our time at Brigham and Women's at Milford, operating primarily at Milford. And we're the same person. I mean, the quality of care that we present to patients at Brigham and Women's, we do the same at Milford Regional Medical Center. And the tools that we have are all identical. I think what people don't realize is that what we do as surgeons is just a small part of a patient's overall care. So much is really after the surgery, what type of rehab, what type of nurses, what type of ancillary, medical treatment they're getting. That quality of care is so important. And Milford has completely been able to recruit world experts in internal medicine and pulmonary critical care, in physiatry and nursing care, that the quality of care that's being provided at Milford is, in my opinion, of the utmost quality than what you would find in Boston.
Yeah, I would echo that. I think it's we made a very conscious effort to make sure that the quality of the care that we're providing isn't compromised, for example, for lack of tools. And if I thought the tool wasn't available that I needed, I wouldn't do the surgery or I'd do it elsewhere. But the reason that we're doing quite a few surgeries at Milford is that the hospital has been very supportive and we absolutely have the exact same tool sets that we do.
So you can go to
downtown.
Uncle Ed and say, if you want to keep us operating in Milford, here are the new toys I need and here's the reason. And he comes through with the money.
And Ed Kelly is such a patient-centric person that he really gets it. If we say, we need this microscope, which we did recently, we said we need a microscope to help us do, the work that we need to do, and we immediately, got the tool that we
your toys
needed.
aren't cheap.
They're not cheap.
When we listen at board meetings and all, you don't have $5,000 microscope.
No. But it's they are expensive. You're right, but it's an investment because it's the tools, like Hassan was saying, that really allow you to do the high level work that you need to do.
Well, I remember when I was first talking with Ed and Uncle Phil, Sarah McCauley, with his ability to bring people in. I remembered when we first started shooting TV shows here in Milford. And the equipment we had when Paul Revere installed it was probably first rate. But it was harder and harder to get the young kids interested. The perspective was so radically different. I remember when the medical show intro, they came to me and said, Mr. C, your show intro is very tired. That analog printer sound. Now, I thought I understood, analog printer, that's the old bzz, bzz, bzz on the green. No, it was a typewriter. And I had to realize that these kids these millennials never grew up using a typewriter or knowing what it was. We moved into this facility, and Rob O'Keefe has put in the latest and greatest state-of-the-art equipment. Now we can draw. So I would imagine, it's the same for you, that if you can't go to somewhere which gives you state-of-the-art tools and state-of-the-art access, you're going to go somewhere else.
Yeah, it's the same principle because it's because we're not going to compromise the quality of the care that we're providing. If it's my philosophy is very simple. Hassan shares it. I know we take care of our patients as if they're our family. So if I don't feel comfortable doing this operation with these tools for my wife or my mother, then I wouldn't do it. And so it's been a very supportive environment as far as that goes.
You know, that's a wonderful philosophy because years ago when I built a little pharmaceutical plant and people would come to me, we were making monoclonal antibodies from either from hybridomas or recombinant proteins from CHO lines. When they asked me a question, I said, if this drug was going into your mother, your daughter, your spouse, what would you do? And somehow it put it right, they knew what was right. And they were just hesitant. But if they thought about, I'm making a monoclone that's going to treat my mother or my daughter, boy, it put everything directly into perspective.
Yeah, it makes life very easy. It's almost like cheating because I sit with my patients, and if there's a lot of gray zones in what we do. There's very little black and white, and you got to talk to folks about it. But if there's ever a gray zone where you go, should I do the surgery? Should I not do the surgery? Should I do a fusion or should I not? If you just think, what would I do for my family member? It almost always makes it very easy.
It's very simple. You look and say, for your mother, for your wife, for your husband, daughter, you know what you do.
Right.
And if you treat your patients that way, boy. And like I say, I was amazed at how comfortable my mother was driving, having me drive her down the street to Milford Hospital. I can't call it that anymore. Ed gets mad at me. The Milford Regional Medical Center. And to her, there wasn't an oncologist named Dr. Cadis. It was Dr. Mona. She's been going there 10 years, and she just felt comfortable. And to keep somebody that long, it's got to be not just the environment, but the tools and the investment.
Right.
So this is exciting to hear, that we're able to bring people from that little school, Harvard, into Milford to want to practice here.
Yeah, and we've had the community is just fantastic. The hospital itself is very supportive and great. But the folks, the people that we're taking care of are just amazing folks. And it's just been a real privilege to be part of this community.
So now you talked about peripheral nerve damage. Okay, carpal tunnel. I understand I type too much and something happens. What happens? So
there's a ligament in your hand that can thicken over time. And sometimes it can be genetic. Some people called acromegalics can develop that more often than not. But that ligament can thicken. And that ligament surrounds a nerve that's primarily going into the hand called the median nerve. But that whole concept of a nerve being crushed, whether it's in your back, whether it's at the base of the skull, same thing in the arm. There's a variety of different tunnels that you can have within which the nerves can get tightened or squeezed and stop functioning properly. And other things that peripheral nerve surgery involves are peripheral nerve tumors. People who have genetic diseases have a higher propensity of developing small little tumors on the nerves at any one or any part of the body, so that can be removed as well.
So now when I think of a nerve, it's confusing, because if I think of a water pipe and I pinch it, I'm squeezing down the volume that water, liquid, fluid can flow through. If I squeeze a nerve, am I slowing the electrons? What's going on when you say I pinched a nerve?
So the better way to think of it, I think, is more electricity and the insulation around the electricity. That is a better analogy, I think, where if you're pinching the wire and that's causing the insulation to wear down, then it's not going to conduct as well. And that's what happens when you get a chronic pinch. You may have a loss in the R version.
So like MS with a myelin sheath just deteriorates, and all of a sudden the brain is saying lift leg, and by the time it gets down there, the signal is so weak it doesn't know.
There's inflammation in the nerve, and that's interrupting the flow of the signals, or causing abnormal signals, and that's what pain is. It's an abnormal signal that's not meant to be there.
Anything else you get involved with besides that brain surgery, that spine surgery?
Yeah.
Well, Omar and I are pretty involved in research also. I think just like Omar alluded to, there's a lot of gray zones. And, as neurosurgeons, we like to be binary. We like to have a yes or a no. And so, although we're never going to get there even in our lifetime, the best way to answer questions is through research. And it's not experimenting on patients, but really looking at what patients we've already operated on, as a community in general, as neurosurgeons, whether we have, in now retrospect, made the right decision for those people. What we're trying to achieve is sort of a moving target. The way neurosurgery was practiced 10 years ago is very different than the way neurosurgery is practiced now. But we can glean some answers by reviewing the patients that we've operated on and understanding, well, this was not correct and we should stop doing it anymore. And there are a lot of procedures that were in vogue 5 to 10 years ago that we're realizing now were not necessarily ideal. And there are procedures that we were not doing that we realize now was much more effective with a small little tweak here and there. And so, we're involved in retrospective research, prospective research, clinical trials. So every patient that we see in our clinic is actually, we collect data on how happy they are. And that's something so granular that we didn't necessarily collect, even 3 to 5 years ago. We tried and asked them, are you not only able to move your leg, but are you able to do the things that you want to do? Are you able to play tennis? Are you able to, spend time with your kids? How happy are you in general overall? Because we're realizing now the ramifications of the operations that we've suggested for patients. It's not just for fixing the leg and allowing the leg to move, but allowing the patient to go back to work and spend time with their family.
So it's the Brigham and Women's Neurosurgery at Milford.
Mm-hmm.
And how do people find you?
The best way to get a hold of us is we have our contact information, which hopefully we can put up at some point. But we're happy to see any patient nearly any single day of the week at Milford. We're primarily
you're
here.
part of Uncle Phil's was Tri-County, but the physicians group of Milford.
No, so
No?
we are Brigham docs who spend, like Hassan said, between the two of us, half our time seeing patients and doing surgery at Milford. But patients can get a hold of us either directly or if they have a primary care doc who's part of that group.
Well, that's what I'm thinking.
They can refer that patient to us. But patients can, if they wish, they can come see us directly.
Okay, and hopefully we'll put up at the end of the show the contact information. Mm-hmm. But our primary care docs would know how to get a hold of you.
Yeah, the community docs know us pretty well.
Well, thank you for bringing brain surgery and spine surgery to Milford so we don't have to go all the way to Boston. We really appreciate you all being here.
It's a pleasure to be here.
Yeah, thank you for having us out.
As always, like I say, every time I think I figured out what Phil and Ed are offering, they come up with new and better options for the people of Milford. Get to know our medical center. I was at another little place called the Mayo Clinic. We were working on artificial organs there. When I said, boy, the attitude here, the environment is really strong. Almost as strong as in Milford. They took a little objection to it, but again, to our 6 loyal viewers, thanks for joining. May God bless, and may tomorrow be a better night than tonight.
Not too long since I've been home. Been running all my life just